Hello everyone. Assalamu alaikum. How are you? Hello, Dr. Shazia. Hello. Hello, Dr. Rashmi. How are you? How are you, Dr. Mawahib? How are you, my dear? Dr. Amna. Walaikum salam. Dr. Fariha. Dr. Sama. Welcome everyone. Assalamu alaikum, Dr. Aruj, Dr. Iram, everyone. Hi, Dr. Nada. We miss you too. I miss you, all of you, my dear friend. Hi, Dr. Samina. Okay, so dear friends, let's have our revision. Okay, as usual. Today I choose to go for the EMQ revision. Yeah, I've collected some important questions and it's complete EMQ, thanks God. So will be a good training for the exam. I hope that you will all do well, inshallah, in this one. Okay, so dear friends, if you are appearing in this coming exam, please, please, please believe in yourself and prepare well for the day of your exam. You had a long journey, and inshallah, your destination is coming, it's approaching, success is waiting for you. So, dear friends, some tips of the EMQs as usual before we start, that try to read the lead and statement first. Okay, so you know what is this EMQ all about. Read the scenario carefully, okay, and don't read the options please first. Okay, so when you read the option you find yourself lost between all the possibilities are there, but we should have our provisional answer in our head first, right? Then we can go to the options and find out what is the available option that can match the answer in your head. You will shortlist 2 or 3 options and then you choose the best out of them. We apply the guidelines, okay? Most probably the questions will be straightforward. Sometimes the question will need a little bit of clinical judgment, sometimes need also a little bit of, situation awareness. Nothing else. People pass the part 2,000 pass every year, okay? So if they can do it, you can do it. My friends, here is my first question, and I need my champion help today, okay, in the questions, and we'll see the first scenario says, for each of the following question, choose the single most appropriate intervention from the option below. And a 26-year-old presented with presented to the E&E with fever, vomiting, severe pain in the abdomen and flank. Her last menstrual period 6 weeks ago. Her urine pregnancy test is positive, and urine analysis show multiple pus cells and epithelial cells. On examination, she is found to be dehydrated with pulse of 98 per minute and blood pressure is 80/40 with rigidity and gardening in the pelvis region. So what do you think the most important or most appropriate intervention required from the list? Yes, excellent, everyone. Okay, yes, excellent. As basic fact, okay, even if you suspect that this patient, she had a pyelonephritis, okay, or even complicated UTI by sepsis, you have to start with intravenous access and urgent pelvic ultrasound. Yes, excellent. Yes, well done, well done. A 16-year-old student attended the early pregnancy unit with mild abdominal pain and not being able to pass urine for the past 12 hours. A recent ultrasound examination showed viable intrauterine singleton pregnancy. On examination, vitals are found to be stable with lower abdominal distension. So what is the situation we face here? This is a primary, okay, with just mild pain and not able to pass urine for the past 12 hours. This is retention. Okay, yes, exactly. Okay, so castration to relieve the acute urinary retention. And this is something that can be seen commonly with the retroverted uterus in the early weeks of gestation. Here we have a 28-year-old woman present to the A&E 30 weeks of gestation with fever, flank pain, and palpitation. On examination, found to be febrile with pulse rate of 100 and blood pressure 100/60. She has diffuse tenderness over the abdomen, soft non-tender uterus, vaginal examination normal, and fetal heart rate is found to be 200. So what do you think? Yes, excellent. It's a high dependency unit. Yes, okay. So now we have a 20-year-old primary present at term +4. Yes, to the delivery suite of induction of labor. She present with fetal movement well. And the obstetric ultrasound is normal. On examination, she is noted to have painful ulcer over the perineum. She denies any difficulty in passing urine or facing similar episodes in the past. Yes, so everybody is correct. Yes, it's a category 3. Well done. Yes, well done. So Miss Elisa, who is primary at 32 weeks of gestation, came with PPROM. On examination, genital herpes is noted and patient confirmed that this is a recurrent episode. What is the next step of management? Yes, so everybody got it at K, which is correct. The valacyclovir 500 mg twice per day and continued till delivery with a plan for expectant management. Yes, well done. So what is the difference between the K, which is actually the guideline recommendation, and F? So when it is a recurrent, we offer only the oral medication, my dear, either the acyclovir or the valacyclovir. Yes, so this is from the guidelines, quoted from the guideline, okay? The patient will receive the care for a PPROM as usual, okay? But here he's just giving you option for the herpes treatment. Yes. So let's see this question and we find the answer. Here in the instructions, okay, what he wants, single most appropriate treatment. A 24-year-old seen at the 24 weeks of gestation, known case of HIV, presented with recurrent vulval herpes. The first episode was 6 months ago and was treated with acyclovir. When she is examined, there is no lesion on the vulva and vagina. Screening for other STI is negative. So what would you suggest? Okay, so guys, why I have seen some suggestion, okay, between HIV start at 22. Why at 22? Okay. So yes, this is the risk of the preterm. Okay. Risk of the preterm, this one, well, yeah, okay. This one, she will have from the 22. But HIV is a risk of increased risk of preterm? No, guys, please, okay? Just stick to the guideline. If the patient have high risk of preterm for any other reason, okay? Like any high risk pregnancy for a preterm, in this case, we consider it as from 22, okay? Now, nowadays, my friends, it simply says, when we have a patient with recurrent genital herpes or diagnosis of genital herpes even prior to the pregnancy, okay, the suppression dose, right? You know this suppression dose, do you remember? Okay, the suppression dose that we will use to reduce the risk, okay, what we will do for it, okay, this is will be, yeah, treat the recurrence if any episode occurred during the pregnancy and give a standard dose of acyclovir if necessary, and consider the acyclovir 400 mg 3 times per day TDS from 32 weeks or from 22 for those at high risk of premature delivery and offer vaginal delivery. Okay, so here, my friends, is part of the update, right? That they say that now no difference in a patient who is HIV positive or HIV negative in terms of management of the recurrent herpes. Why? Because in the previous version of the guideline, we used to have the suppressive dose at 34, right? And then we give for the HIV earlier, okay? And earlier was 32. Now everybody with recurrent herpes or even they got a primary herpes, but in the first or second trimester, we will treat the same as per the algorithm and we will start at the 32. Okay, guys? Okay. I have one question in this chat box asking what is the difference between acyclovir G option or J option. Simply, my friends, Acyclovir 400 mg TDS until delivery means that I will start today. The patient today is 24, right? It's even 24 weeks of gestation, right? Okay, but shall I continue from 24 weeks till delivery? No, okay? I will start from 32 until the delivery, okay? Because this is documented. At the moment, the patient have no lesions on the vulva and the vagina, okay? So at the moment, okay, I am not going to give her the acyclovir for the time, but I will consider, based on the history of herpes before, the suppressive from 32, okay? If it is a recurrent herpes, okay, then the patient can go for normal vaginal delivery, even if there is active episode. Why? That's okay. That's simply because there is an immunity, okay? So the patient have immunity. Why we deliver primary episode by cesarean section? Why? That's because the maternal antibodies is not well developed yet, okay, and passed to the fetus. But recurrent episodes, they have a good chance, okay, to go for a normal vaginal delivery because the risk is between 0 to 3%. Okay? No, again, if there is active lesion and require, okay, require a treatment, my friends, if there is active lesion and require treatment at 24 weeks, treat for 5 days and then stop and then start from 32 again. Okay, again? But I don't need to continue from 24 weeks till delivery. Right? I don't need to do that. Yes, excellent. Okay, I have a question asking me, sorry, here about the PPROM, right? Or a preterm. Is it the valacyclovir only for the preterm and the cyclovir for term? No, no, no. Okay, both can be used now. Okay, so the antiviral suppression can be done either by the acyclovir, and the acyclovir dose is 400 mg 3 times per day, or the valacyclovir 500 mg twice per day. That's it, okay? So both can be used. There is no problem in that. Okay, I will answer one by one. The question says, so the answer is with HIV start from 32. Nowadays, there is no difference between HIV and non-HIV, okay? Nowadays, my dear, we treat both the same, okay? Recurrent herpes will start the suppressive dose from 32, okay? What is the... Okay, so may I ask you, my friends, who suggest that HIV is a risk of preterm delivery? Is there is anything in the guidelines of HIV, for example, suggest circulage because the patient have HIV, or suggest a progesterone because the patient have HIV? No, I can't really answer someone else. Okay, I'm sorry. Okay, I can't answer someone else questions. Okay, and I can't comment because maybe there is different questions. Okay, but dear friends, the HIV, yes, prone for bacterial vaginosis. Shall I give? Okay. Okay, so even if, yes, I agree, prone for bacterial vaginosis, but is that also still a high risk of preterm? Okay, so it's a good idea. Okay. Yeah, that I will send you, dear friends, a version of the guideline. 2 recurrent in the same pregnancy, treat both, and suppressive dose. I found this in the questions bank. no problem. 1 episode, 2 episodes, okay, whatever the numbers of the episodes, and it happened in the first and the second trimester, you still treat at the time if necessary, and then you start a suppressive dose from the usual timing. Okay? American study demonstrated this by a pregnant woman living with HIV. Risk of spontaneous preterm. Okay, 1 second. Okay, just hold on. Give me 1 minute, my friends. I'll open the guideline itself and then we can discuss it, because unnecessary we are, okay, debating something that's very clear. Okay, this is, my friend, from the guideline, and this is the management of mothers and pregnant people with diagnosis of genital herpes prior to pregnancy, or including those with recurrent herpes during the pregnancy. Okay, so we will start at the first antenatal booking appointment, and later, if appropriate, all mothers and pregnant women should have a discussion, okay, and information about infectious disease, okay, and then we will do, okay, like in the history taking, if they have any previous, okay, episodes or not, and we should document that, of course, right? Mothers and pregnant people with diagnosis of genital herpes prior to pregnancy should be informed that the risk of neonatal herpes is low, even if the lesion are present at the time of the delivery, okay? So even if the lesion are present at the time of delivery, what is the risk of transmission? It's 0 to 3%, okay? So the question that is, there was a recurrent lesion at the time of the delivery. Then what is the management? This patient can continue with normal labor? Yes, she can. Why not? This is one question from the chat box. And that is no increase in the incidence of congenital abnormality, right? In the presence of recurrent genital herpes. Mothers and pregnant people with previous genital herpes diagnosed should be referred to genitourinary medicine physician who will advise on management of genital herpes and arrange a screen for other sexually transmitted infections if required. Mothers and pregnant people with previous genital herpes diagnosis who have midwifery-led care should be referred to review by obstetrician and have review by the GUM clinic, okay? The neonatologist should also be informed, and delivery and postnatal management plan documented involving the everything, okay? So let's skip this part and see. Regarding the suppressive antiviral, okay? The suppressive antiviral for all mothers and pregnant women with known genital herpes should be recommended regardless of whether the SFE, the herpes, okay, recurrence occurred during the pregnancy. This reduced asymptomatic herpes shedding and lesion at term, and may also reduce premature delivery. However, maternal antiviral suppressive therapy have not been studied sufficiently to definitely demonstrate that it prevent neonatal herpes disease. Acyclovir and valacyclovir have not been associated with increase in the major birth defect when given in pregnancy, and should be given at the following doses. Doses for all mothers and pregnant women: acyclovir 400 mg 3 times daily, or valacyclovir 500 mg twice per day from 32 of gestation. Okay, so this is very clearly regarding repeated episode or recurrent episode of herpes. Any doubt in that? No. So now here, this is a section regarding when to start the suppressive therapy or the suppressive treatment for the women who have high risk of preterm delivery, okay? For all mothers and pregnant people assessed as being at high risk of premature delivery, acyclovir 400 mg 2 times per day, or acyclovir 500 mg 1 per day from how many weeks? From 22 weeks, okay? Followed by acyclovir 400 mg 3 times per day, or valacyclovir 500 mg 2 times per day from 32 weeks of gestation. So I'm giving this to which woman? high risk of preterm delivery. Okay? Right? So, what is the meaning of high risk of preterm delivery? Then just refer to the preterm delivery guideline. Clear, my friends? If there is any mention here that HIV will start from 22, no. Okay, let's go now and see, okay, the correlation between the HIV and herpes. Nowadays, okay, this is becoming a little bit different from before. Different and not different, and I will explain to you how. Okay, 1 second. Just down. I remember it was here. No, this is not the pre-labor. This is the recurrent herpes. Yes, this is the part or the section with HIV. Management of mother. It was the only answer that correct Dr. Heba in the previous question. Okay, in the P-prob question. I wrote the options and I'm aware this is the only one that is correct. So, management of mothers and pregnant people living with HIV with herpes infection. Okay, so there is evidence that a correlation exists between the herpes virus 2 diagnosis and HIV vertical transmission. However, studies are difficult to interpret given that many did not adjust for antiretroviral therapy use, and an association is often not demonstrated in studies adjusting for effective ART. Genital shedding of herpes virus 2 or herpes virus ulceration, a term, are not consistently associated with vertical transmission of HIV, and again, many studies don't adjust for ART use among other important factors. Management of mothers and pregnant people living with HIV is now aligned with treatment for HIV negative women and people. Refer to the relevant section of this guideline. So what do you think, my friends? Where is the recommendation to start from 22? Okay, happy now? Okay, that's good. So, dear friends, I just want to say something, okay? That every question is different and every situation is different. And I can't really comment, okay, on any respected colleague answers, okay? I respect all my colleagues and I respect their opinions. Maybe, okay, the context is different. Okay, dears? But for our case here, she is just HIV, okay? And no risk for the preterm delivery is mentioned, okay? So what I will deal with, I will deal with her as a case of recurrent herpes, like she is HIV negative. Nowadays, the guideline, as you can see, sorry, okay, no, I will show you in the file that I prepared better. This is upside down. Okay. Let's go back to our file and continue the questions. I would like really to answer all of your doubts one by one. So, any case, dear friend, any case who have diagnosis of one sexually transmitted disease should be screened for all other sexually transmitted disease. It's a rule. Okay, okay, dear? So it's not only for the herpes, actually the same thing apply for all sexually transmitted disease. Okay. Okay, so let's see here. Suppressive dose. When to start a suppressive dose earlier than 32 when the patient have risk of, yes, it's recording, the recording is on. When the patient have risk only of preterm delivery. Otherwise, recurrent, go for 32. When to go for the whole trimester. Okay, yeah, this is if the lesion or the primary episode, primary episode of herpes occurred in the third trimester. If it's a primary episode in the third trimester, what is the advice? The advice is to treat the primary episode with a standard dose of acyclovir and consider acyclovir 400 mg TDS till delivery. Okay, dears? Recommend planned cesarean section if the woman have a primary herpes in the third trimester, especially if it is in the last 6 weeks. Okay, friends? Why? Because the risk of the transmission in cases of primary herpes is 41%, which is very high. And we are afraid that the baby will develop the neonatal herpes syndrome. A standard dose for herpes, okay, for the herpes simplex is 403 times per day. This is the standard dose. And take care because it's different in other viruses. What is starting from 3028? Dr. Hema, please explain your question more so I can answer. What is starting at 28? Third trimester, yes. Third trimester starting at 28. Up to 27 plus 6 days is still second trimester. Suppressive dose is 400 mg TDS from 32. This is for the patient who have recurrent. If the patient is a primary episode, start the treatment in the third trimester and continue till delivery. Okay? Okay, I'll tell you when to use the IV in the next question. Okay, dear? This is in the next question. We will see when to use the IV acyclovir. Okay. Mrs. Talia, who is gravid 2 para 1 at 30 weeks of gestation, came with PPROM. On examination, painful shallow ulcers confirmed to be genital herpes. She denied having this lesion before. What is your next step of management? So the lady here, she came with a primary herpes at 30 weeks. Sorry, not 32. What you will do? Look, my friends, shall I deliver this lady now or shall I wait for a conservative management? What do you think? Yes. So there will be an MDT. Of course, they will meet together and they will decide what is the best for this patient. But there is a rule of conservative management in this case, which is okay. Yes, that's because this is before 34 weeks. Yes. Okay, so dear friends, you are almost answer correctly. Okay, take a steroid now or not? No, we can give a steroid now because simply, my friends, yeah, this is a preterm delivery and all the recommendation of preterm delivery, sorry, PPROM, all the recommendation of PPROM apply in this scenario. Okay, but we are bounded by options in that exam, right? So according to the option, you have to choose the best option out of this. No, steroid is not contraindicated in viral infection. The patient still will receive her steroids and will receive, yes, antibiotic if she is in active preterm labor. If she had PPROM, she will receive the erythromycin as usual. There is no contraindication in this case. Yes, so the answer among all the options. So guys, yeah, some of you chose K, some of you chose L, some of you, yeah, choose F. Okay, so most of the answer between K and L, let's compare between both of them. K says the valacyclovir 500 mg twice per day, which is an oral, okay, and continue till delivery with a plan for expectant management, right? This is a good option for recurrent herpes with PPROM. Okay, this is a good option if it is a recurrent herpes with PPROM. Oral, okay, till the delivery, there is a plan for expectant management, no problem. But L says IV acyclovir 5 mg per kg every 8 hours and continue till delivery. Okay, so L is the correct answer. Okay, and here, this is the reason. Okay, this is a comparison, my friends, between, right, a primary genital herpes in preterm pre-labor rupture of membrane or a PPROM, or a recurrent genital herpes. So the difference between this question number 7 and the question number 5 is what? 1 second. The 5 question. What is the difference? The difference in 5, it was a recurrent episode. But in 7, it's primary. Okay? Okay. So, difference, my friends, in the management is stated here. Right? If the decision is made for immediate delivery, then the anticipated benefit of cesarean section will remain in reducing the risk of neonatal herpes. If there is an initial conservative management, mothers and pregnant people should be recommended to receive intravenous acyclovir 5 mg per kg every 8 hours until delivery, with the same words of the guideline. Okay, friends? Okay, so I don't care if this is, my friends, I don't care if this is occurred at 27 weeks, if this is occurred at 26 weeks, if this is occurred at 31, 32, 33, 33 plus 6, okay? As long as it's below 34, okay, the management will be for the primary herpes and PPROM is by the MDT. There is a plan for a cesarean or a plan for a conservative management. Who will decide? This is the MDT team, not me, not any one of us, okay? Yes, the same line from the guideline. Receive intravenous acyclovir 5 mg per kg every 8 hours until delivery. Who will decide delivery? It's the MDT. So don't worry about when is the delivery. Okay, dear? A PPROM means a pre-labor rupture of preterm pre-labor rupture of membrane. Okay, this is the meaning of PPROM. So it's basically it's a preterm. Okay. For each of these patients recently diagnosed with HIV, choose from the above option list the single most effective plan of care. What is the single most, okay, most effective plan of care? In a 32-year-old woman attended for her first antenatal visit and agreed to be screened for HIV, confident that this will be negative. She had just been informed that she is positive for HIV. She had been counseled and investigations instituted and about to be commenced on combined antiretroviral therapy, CART. You have seen her and are concerned about her state of mind. What you will do? Best plan. Yes, exactly, everyone. Yes. So what the guideline says regarding the mental health screening for HIV patient, assess her for depression. It should be at booking. However, our patient already have her booking blood test. Then at 4 to 6 weeks, and again, 3 to 4 months is postpartum. Okay, yes. So how many of you guys appearing in July? July group? Hi. Hello, everyone. Yeah, okay, that's great. Okay, because I've just finished the HIV, discussion with the July group yesterday. Yeah, and yeah, today is the day where we are discussing together the quiz. Yeah, yeah, I know. My idea today, this session is for mainly January, but of course, everyone is welcomed. Inshallah, all the best, Dr. Hab, in your exam. I know that you worked hard through the last 5 to 6 months. I have witnessed that, and I can see that you are improving. Your level is becoming now very, very good. Inshallah, you will pass. Okay, so this is the screenshot. Inshallah, Dr. Ahmed, you as well. You worked very hard, and I can feel all the tense, you know, and all the stress that you are in. But I can reassure you, you did very well so far. Okay, inshallah, all your efforts, all your hard efforts will be paid off. إن الله لا يضيع أجر من أحسن عملا. إن شاء الله. A 25-year-old woman booked for antenatal care at 10 weeks of gestation 3 months ago and was screened positive for HIV. She was screened for sexually transmitted infection, STI, counseled and baseline investigation performed, and then commented on CART. Despite repeated attempts to convince her to discuss this with her partner, with whom she is still having unprotected sexual intercourse, she had not been able to do so. So what you will do in this case? Yes, straightforward. You will have to warn her, and if not, break confidentiality. Yes, do no harm. Exactly. Okay, so the question number 10, the women described below are HIV positive at various stages in pregnancy. For each woman, select from the above option list the single most applicable next step in the management. An HIV positive primate presented in labor at 36 plus 6 weeks of gestation, and she has been compliant on CART since 14 weeks of gestation, and her viral load was less than 50 HIV RNA copies per ml at 36 weeks. So, what you will advise? Excellent, everyone. So, yes, she had a controlled condition. Her viral load is less than 50. So, we will go for a vaginal delivery. So, answer is A, allow progress of labor and anticipate vaginal delivery. An HIV positive primate presented with PPROM at her 27 weeks of gestation. She had started her CART at 20 weeks. So, what is your advice? Okay, so the question is, yeah, yeah, exactly. Okay. If the patient have PPROM, right, and she is HIV, if this is found to be less than 34 weeks as per the guideline, okay, so what we will advise when the premature SROM occurs at less than 34 weeks, then intramuscular steroid should be administered in accordance with national guidelines. Where HIV viral load is not controlled, this should be optimized, and there should be MDT discussion about the timing and mode of delivery, right? So steroid can be given in viral infection. Yes, it can be given. Why not? Okay. So you will manage the PPROM as usual. So we had a previous question on the herpes, and there was no steroid because simply, okay, these are the options, and we are bounded by option. You choose the best among the available options, right? So the patient will start on the steroid and antibiotic along with the CERT. Yes, exactly. Question 12, a 26-year-old woman has attended the clinic for a chorionic villus sampling on account of raised NT. She is 13 weeks of gestation. She reported developing a rash 24 hours ago, for which she was prescribed acyclovir by her GB. So what do you think? Yes, simply, yes, defer the test till the rash is crusted over. Yes. So it cancel the screening test means that we will not do it ever, okay? But we will just defer it, crusted over. A 26-year-old woman has attended the clinic for amniocentesis for fetal karyotyping as suspected fetal abnormality. She is at 22 weeks of gestation, diagnosed with HIV, but only started CRT 2 weeks ago. Yeah, they like to ask all this. Yes, so yes, exactly. Yes, if the screening is necessary and it can't be delayed till we got her viral load under control, then we can use, yes, the nevirapine. Here is the recommendation from the guideline, right? So this is says for the screening for Down syndrome, for example, or fetal. But if myosynthesis is required, it's better, okay, that invasive prenatal diagnostic testing should not be performed until after the HIV status of the woman is known, and should ideally be deferred until HIV viral load has been adequately suppressed to less than 50 HIV RNA. If not on CART and the invasive diagnostic test procedure cannot be delayed until viral suppression is achieved, it's recommended that the woman should commence on CART to include ratigravir and be given a single dose of nevirapine 2 to 4 hours prior to the procedure. So the best answers that we have here that can be applicable for this scenario is the one that contained the nevirapine 2 to 4 hours before. Okay. Yes, well done, my friends. If the infant of HIV positive mother, yeah, question 14, conceived on CRT. So she's already on a CRT. She was very compliant with prophylaxis and all occasions during pregnancy, the plasma viral load less than 50. Okay, well done. And during labor, she was given intravenous zidovudine and has decided to breastfeed exclusively despite advice to the contrary. So what you will do or what you will advise for a woman who insists for breastfeeding, okay, her child while she is HIV positive. Of course, her viral load is a good level, less than 50. However, a close monitoring for both mother and fetus is required. The question here, which answer is the correct one? Yeah, so we use it monthly. Yeah, HIV is said during the first 48 hours at 2 weeks of life, and then monthly for the duration of breastfeeding, and then continue for 2 months at 4 and 8 weeks after cessation of breastfeeding, and then maternal antibody at 18 and 24 months post delivery. Well done. 26-year-old primey at 36 weeks of gestation seen at the A&E with complaint of confusion and palpitation. She's known type 1 diabetes and on insulin. Examination revealed dehydration, tachycardia, and tachypnea. Urine examination showed ketonuria. Yes, so answer is E. Well done. This is an emergency, correct? Right? And it's diabetic ketoacidosis. Yes, well done. A primary being induced at 2 weeks post-term. She's on oxytocin infusion and fetal heartbeat is being monitored continuously. Last examination show 5 cm dilatation with a bag of membranes which is ruptured. Liquor was clear. She complains of severe chest pain and breathing difficulty. Her pulse rate is 102 and blood pressure is 90/60. Yes, exactly. Okay, so call for help first. Choose the single most appropriate option. A 37-year-old postnatal mother presents with cough pain. She is diagnosed with recurrent DVT and receive therapeutic dose of low molecular weight heparin. She is otherwise well and not stable. Further evaluation show a right common iliac vein thrombosis. Yes, it's the inferior vena cava filter. Well done. This is because this is a recurrent. Yes. 28-year-old primary present to the A&E at 16 weeks of gestation with chest pain and breathlessness. She smoked 15 cigarettes and she has not seen her midwife or GB yet for her pregnancy booking. On examination, she's found to be very pale, dyspneic, with pulse rate of 112 and respiratory rate of 30. She's clinically stable and admitted to the high dependency unit. So what will you advise? Okay, so if we have to choose between, I can see, okay, initial resuscitation, K, basic blood, full blood count, coagulation profile, and liver function test, okay? So the patient here was admitted already where? High dependency unit. So we understand from this that initial is done, right? She's clinically stable at the moment. Yes. So a K is not for this situation. Okay. Other option is between H and C. Okay. So guys, will you start the low molecular weight heparin at that moment, or will you go for the ECG and chest X-ray? So again, okay, we are managing a patient, right, who is admitted. Okay, so what I'm going to do in acute VTE, will I need to go for diagnostic procedure at the moment, or shall I start the low molecular weight heparin? Okay, so in this case, since the patient is seen in the A&E, okay, as we said, the reflection investigation will be done at the A&E, right? And then this patient is admitted to the high dependency unit in view for the pulmonary embolism, right? And then we can start the low molecular weight heparin, okay, while you are preparing yourself for further investigation. Correct? It doesn't matter there is a DVT or not DVT, right? We are dealing with a pulmonary embolism, so based on the clinical suspicion, right, we will go. So after the initial resuscitation, right, the treatment dose would be commenced. Further investigation to confirm or defer the diagnosis of pulmonary embolism will be arranged. A and A&E, yes, A&E is different from the setting is different, right? So here, my friends, when we say the importance of situation awareness, right? No, directly CTPA. No, I didn't say directly CTPA. We said commence low molecular weight heparin, enoxaparin, okay, 1.5 mg per kg in the body weight, and then you go for the CTPA or according to the X-ray result. Okay? Yeah, that's why this is the importance where he mentioned to you in the patient is seen first in the A&E and then admitted to the high dependency unit. Means that the initial actions is done. Answer is C. If you have a good situation awareness, dear, you will not lose the marks, right? Now you are expert with the MRCOG tracks. Okay. A 23-year-old primey at 38 weeks of gestation complains of reduced fetal movement for the past 2 days. Her antenatal course was uneventful and her current observation within normal. Further evaluation show normal estimated fetal weight on ultrasound with marked oligohydramnios and normal uterine artery and MCA Doppler studies. She denies any vaginal discharge. Vaginal examination show a Bishop score of 5 and membrane sweep has been done. Okay, so I can see IMN. Oral misoprostol 200, 25 mg. Okay, yes. And what is the other answer? Amniotomy followed by oxytocin infusion. Okay. What is the answer? Why not N? What is N? Vaginal prostaglandin E2. Okay. Counseling and the informed discussion. Okay. Okay. So my friends, first of all, we need to revise an important point here, right? How you will decide on the method of induction, right? According to the Bishop score. So he was very kind in this question, right? And he give you the Bishop score of the patient. So what is the Bishop score given here? It was 5, right? So when we have Bishop score of 6 or less, okay, then we will go to this way of induction, right? We will offer dinoprostone, okay, as vaginal tablet, either gel, right, tablet or gel, or controlled release vaginal delivery system. Correct? Okay. Or what is the next option? Next option is low dose 200, sorry, not 200, so sorry, 25 microgram oral misoprostol tablets. The low dose misoprostol nowadays is available in the UK, right? And it's cheap and effective, right? Or mechanical method to induce labor, for example, a balloon catheter or osmotic cervical dilator. If pharmacological methods are not suitable, for example, in a woman with high risk or from hyperstimulation, or those who have had a previous cesarean birth, or the woman choose to use mechanical methods. This is the difference. When to choose amniotomy and intravenous oxytocin? This is if we have the Bishop score, what? More than 6, right? So things are now very easy and clear regarding the choice, right? Okay, so options here give me what? Options here give me the vaginal prostaglandin E2 gel or the vaginal misoprostol 25 or oral misoprostol 25. Okay, so if I go to the guideline stepwise approach one by one, which option is applicable, more applicable? The vaginal prostaglandin E2 gel first, right? Right? Yes. Look, guys, 1 second. Here, the alternative is oral misoprostol, not vaginal misoprostol. Okay? So the alternative is the oral. So if I have to choose between I or N, I will go for N first because the guideline advised it at first, and N and I is the alternative. Okay? Right? Okay. So I will go for N first. The dinoprostol. Yes. Do you have any significance? The situation required delivery, right? Right? The presence of oligohydramnios, however, there is normal Doppler, means that, and reduced fetal movement means that this is an indication for induction of labor, right? Indication for induction of labor. This is the implication of it. Then, okay, I have to choose the method of induction. Based on what? Based on the Bishop score. Bishop score 6 or less, go for dinoprostol as vaginal first, tablet or vaginal gel, or controlled release vaginal delivery system, or the alternative is the low dose oral misoprostol 250. Oh my God, I'm so sorry. I don't know why my tongue is twisted today. I'm so sorry. 25 microgram, 25. Okay. Since we have normal Doppler, I'm not worried about the baby. Anyway, the baby will be under a close supervision, right? And continuous CTG since it's induction of labor, correct? So don't worry about the baby, guys. He give you that the baby had everything, the Doppler is normal and everything, okay? We need to induce only because of the reduced fetal movement along with the oligohydramnios. If the Bishop score is 7, for example, for a patient, then amniotomy followed by oxytocin infusion is enough. Right, my friends? A 24-year-old woman who is third gravida attend the antenatal clinic with her third trimester ultrasound report at 37 weeks of gestation requesting delivery by cesarean section. Her previous 2 pregnancies were spontaneous miscarriage at 8 and 10 weeks of gestation, respectively. She underwent surgical termination and had received anti-D both times. Her indirect Coombs test negative, and she's noted to have polyhydramnios with AFI of 20. Fetal umbilical and middle cerebral artery Doppler studies within normal. No other obvious anomalies were noted. Yes, a good counseling, of course, right? Yes, good job, my friend. Okay, the acceptable answer among all of these. Yes. Okay. Oh, in the previous question, here, the patient have polyhydramnios, right? And a polyhydramnios, right, at 37 weeks, right? So, what is the advice for delivery in this case? What's your own advice of delivery? Because there is risk of preterm, but not in this case, unstable lie, cord prolapse, antepartum and postpartum hemorrhage, even placental abruption. Why to go for a cesarean section? By the way, it's not a recommendation. Guys, this is considered as a mild polyhydramnios, right? And actually the AFI is, yeah, is only 20, okay? This is not, yeah, yeah, she requested, right? So if she did not request, okay, cesarean section, you will, yes, you will just manage the labor as a high risk delivery, but we don't have any recommendation, right, to go for a cesarean section in this case because of increased AFI, right? I don't have any recommendation. Yes, it's a high risk delivery, right? And actually, the TUG article was saying that there's no benefit from induction of labor for isolated or unexplained polyhydramnios, right? So, yeah, she will be managed, yes, but the risk of the delivery, risk of intervention, risk of unstable lie, risk of cord prolapse, and so on. But I don't recommend cesarean section because only isolated polyhydramnios. Yes. Okay. 30-year-old Brimey comes to the delivery suite with regular uterine contraction and leaking vaginal for 4 hours. She completed 39 weeks of gestation with uneventful antenatal period. She perceived fetal movement well. On examination, it was found that her uterus contracting well and vaginal examination revealed 4 cm dilated, well effaced cervix and vertex minor 3 station. Clear liquor is needed. Is noted, sorry. So what do you think? What you will do for this case? Why oxytocin? Do I need oxytocin? Yeah, intermittent auscultation is required. This is no problem at all in this delivery. Yes, correct. Yes, let's see next question. A primate is being induced for oligohydramnios and reduced fetal movement at 39 weeks of gestation. She is known to have 8 cm fibroid near the fundus. Serial gross scan within normal limits. Oxytocin infusion is commenced and continuous fetal heart monitoring is reassuring. She was noted to be 4 cm dilated and amniotomy performed. 4 hours later, repeat examination showed the cervix to be 6 cm dilated with minimal clear liquor draining. So what you will do? Why oxytocin? Oxytocin is already commenced. Is that a good progress or not a good progress? Delayed second? No, this is 4 cm dilated after 4 hours become 6 cm. Is that enough? Yes, this is okay. No, she was 4, now 6. Yeah, everything is fine. Shall I go for intermittent fetal monitoring with oxytocin? Okay, guys, focus. Okay. Yes, you have to focus. Yes, exactly. Simply, my dear friends, we will continue the CTG. Yes, well done. Why we would do a fetal scalp electrode? Is there is any indication for that? Is there is any problem with the fetal heart rate? No, she's stable. The lady is fine. Why don't you believe? Yes, sometimes, guys, in the exam, it can be difficult to believe that the case had no tricks at all. It's straightforward. Oh my God, is it real? Is that the RCOG exam? I doubt. Yeah, because of that, so many tricks we face every day. So we can't believe that there is anything simple. Yes, we use word tricks. Okay, so my friends, may I ask you for a little bit break and then come and continue our questions? Yes, thank you very much, my friends, because we are going to come to discuss some of the labor scenarios. Okay, so you have a little refresh and come back. Thank you. سبحانك لا علم لنا إلا ما علمتنا وإنك أنت العليم الحكيم. بسم الله. Okay, so dear friends, welcome. And let's see the first question that we have after the break. Okay, I promise it will not be so long a discussion. My friends, we do have a 35-year-old para-2 presenting spontaneous at 39 weeks of gestation. Her baby is identified to be in the breech position. She is progressing well in labor with no evidence of fetal compromise. After discussion and identification that there is no contraindication, she wishes to attempt vaginal delivery. When conducting her vaginal delivery, an experienced practitioner should routinely do what? Please look to the options and tell me. Offer epidural, are you sure? So, guys, just have a look, okay, to what is the thing that can help the vagina progress of the vagina. Again, when we say the situation awareness, right, that's mean you have to take care, right, of the trick in the question. The Situation awareness here says what is the routinely done. Okay? Is lofted maneuver routine? Or should we revise all the management of breach again? Look, my friends, so we remember in the management of breach that there is very important rule. What is a very important rule to apply in the breach delivery? Look, my friends, so we always say that if the position in, the position in flexion, right? So everything should be going fine, right? It should go fine if it is in flexion, right? Yes. So in the delivery of the breech, the first rule by the RTOG says that hands-off technique, right? What is the meaning of that? The meaning of that is that you will just leave the lady, right, to progress, right? And we do interventions when it is required, okay? So there is an indication for each intervention. So if you go to the journey of the breech, right? The first thing that if the woman is reached fully dilated means that she is 10 cm dilated, okay? We don't encourage her to push or anything. We'll just wait for the breech descend naturally, right? Yeah, and the adequate descent of the breech actually in the passive second stage, this is one of the prerequisites for encouragement of the active second stage, right? So yeah, unless it's needed, no maneuvers is required. Well done. Okay, so answers that I have seen here says offer epidural anesthesia. Actually, epidural is not contraindication in breech. Okay, it's not a contraindication, but the woman, if she requested epidural or epidural was required for her, like for example, poor contraction require oxytocin, the woman should be informed that epidural with breech increased risk of interventions. So it's not routine, right? So I don't choose over epidural here. When to use the Lofted maneuvers? There is an indication for the Lofted maneuver? Yeah, so if the arms are flexed, right, it should be delivered, right? But in the case of nickel arm or extended, then we can consider the Lofted maneuver. So it's not routine again. Okay, so what is the thing as a good practice, however, it's not a maneuver? This is to consider suprapubic pressure to the head by flexion. Okay, so the answer is A in this case, right? Lithotomy position is not encouraged routinely. Okay, we actually against that the woman stay during labor in the lithotomy position. Yes, so either the semi-recumbent or sometimes to stay upright, anything that can make her comfortable, okay? But we don't advise her to lie on her back for a long time in the lithotomy position, okay? For assisted vaginal breech delivery, which one is correct? Fundal pressure is not advocated by the RCUG. They don't agree for it. Can I deliver the baby by extension? Is extension a good option for delivery in extension is against the delivery, okay? This is like a rule. Upward traction should only be commenced when the fetal chin has reached the perineum. Okay, this is the answer. So when you guys think of the Barnes-Marshall method involve delivering the baby by extension, how you will deliver the baby by extension? This is, yeah, no mechanism of labor. The why not B? Mortis-Millivit maneuver involve delivering the baby by flexion, okay? So far here we are okay, but let's see, by placing one finger in the baby mouth, is that good? No, not in the mouth, never. Why? Because it will lead to dislocation of the mandible. Yes, right? So the pelvic grasp in lofted maneuver is a routine part of delivery. So again, we said not routine, right? Regularly, forceps should always be used to deliver the fetal head. No, we actually use in the after-coming head, according to the RCUG guidelines, the paper forceps, not the regular, right? Fundal pressure, no, RCUG doesn't like fundal pressure. So only D is correct. Upward traction should only be commenced when the fetal chin has reached the perineum. Okay, friends? Okay, one question in a preterm. A 32-year woman, gravida 2, para 1, at 30 weeks of gestation is uncomplicated pregnancy, attend the day assessment unit. Complaining of losing a gush of fluid through her vagina 2 hours ago, followed by irregular intermittent abdominal pains. Fetal movement are reassuring as the fetal heart rate pattern. The uterus is soft and non-tender with no palpable contractions, and Simpson's fundal height is appropriate for gestational age, as plotted on her customized growth chart. This trial speculum examination revealed the clear fluid pooling in the vagina. Cervix is closed. Woman has no past medical history or drug sensitivity. What is the most appropriate initial management plan? Situation is PPROM, right, at 30 weeks. What you will manage, what you will do for the management now. PPROM require antibiotic, right? Steroids, good. Correct? Okay, can I give coamoxiclav? No, I can't. So this is wrong. Can I admit to the antenatal ward and prescribe erythromycin 250 mg oral 4 times per day and a course of antenatal steroids? Maybe. So let's see. Admit to the labor ward and commence intravenous atosaban and course of antenatal steroids. Do I need tocolytics in this case? I don't need tocolysis. Discharge home and prescribe coamoxiclav? No, no. Discharge home and prescribe erythromycin and a course of antenatal steroids. So can be an option, but first, my dear friends, you need to know that when we have a PPROM case, okay, we keep the case at least for assessment to make sure that there is no infection, okay, and she's not progressing in labor. And after everything is stable, she received the steroid and go home. Okay, dears? So what's your answer finally? B. Yes. A 28-year-old preemie is being induced for gestational diabetes. She's now at 38 weeks of gestation. Okay, so what is the situation? She had gestational diabetes. And she is 38 and on insulin therapy. Her recent blood sugar and hemoglobin A1C high. She had a vaginal prostaglandin E2 gel. Okay, this was in, yes, given in the previous night. The following morning, sorry, her cervix is found to be 0.5 cm long and 2 cm dilated. Oxytocin infusion is started after amniotomy with continuous fetal heart monitoring. Okay, 4 hours later, vaginal examination reveals 4 cm dilated. 4 hours later, she's found to have fully dilated. Okay, with vertex presentation at -2. She's encouraged to push, and 2 hours later, vertex at +2. With a small caput and fetal heart rate is reassuring. So, what is your suggestion for this case, please? Please give me answer and just think about the scenario. Before you go to the options, think what would I do in this case according to this situation? Progressing well or not well? Need help? Doesn't need help? What do you think? Yes, she is in the second stage for 2 hours. Then what you will do? Okay, so let's see. Okay, do I need to give a help in this case? There is anything wrong in the progress of this lady? So she is fully dilated with vertex presentation at -2. Okay, she is encouraged to push, and 2 hours later, okay, vertex at +2 station with a small caput and fetal heart rate is reassuring. Okay, so what you will do? Castration and expectant management. Why castration? The baby descended well, descended from -2 till +2. This is actually a good descent. The caput is small. Fetal heart rate is okay. What is the guideline says regarding the management in this case? 2 hours in the second stage, okay? I can discuss with her the instrumental delivery, right? Or I can give her a chance, right? Or not? What do you think? No, when he didn't mention epidural, then it's not there. And by the way, it's a nice guideline, okay? Nowadays, give you no difference between epidural and not epidural, only GTG. Will you give a chance or will you expedite delivery? Choose one, please. Overall progress is, what do you think? Overall is good, right? Yes. Okay. Overall is good. Yes. Okay. So I can say, yes, it's a good have a chance. The guideline does not say don't do that. Guys, here I need your clinical management. Why? Because we do have two situations. In one guideline, it says that can be an indication for assisted vaginal delivery. If the woman have a primary, right, had 3 hours, right, in the second stage with epidural, or she had 2 hours without epidural. Correct? So can be an indication for assisted vaginal birth. However, the NICE guideline of intrapartum care says for the primary, right? If the primary spend 1 hour, spend 1 hour, okay, in the second stage and not delivered, what you will do? One by one. Okay. One hour of active pushing in nulliparous with or without epidural, there is a sign of progress in terms of rotation or descent of the presenting part, encourage the woman to continue pushing, right? If there is no signs of progress, offer vaginal examination and consider amniotomy if the membranes are intact, okay? And if there is still no progress, diagnose delay and escalate for senior review. If the birth is not imminent after 2 hours of pushing, refer the woman to senior review and decision on place for the mode of birth. Right? Okay, so I need to deliver her now. Please tell me what to do. Yes, everything, yes. So I'm now here in the gray zone, right? So I can even apply low forceps or, yes, or a ventouse, right? Or, yes, or I can just give some time, right? Okay. I have the GTG indicate that this is the time for intervention, or this is the time when you can consider or discuss with her the assisted vaginal birth. So let's see, my friends, what could be the answer is in here. Abandon vaginal delivery and proceed to cut one cesarean section? No. Okay. Category 1? No, no, no. Category 2 cesarean? No, I don't need cesarean. She is progressing well for vaginal. Castration and expectant management. Why castration? I don't have any clue that she had a full bladder or there is no problem with there is high head or something. So I don't have. Epidural anesthesia and continuous fetal monitoring. Why epidural? She is already in the near to deliver, right? So this is not no need for the epidural. Episiotomy and epidental block. Why episiotomy? Episiotomy if after crowning, right? Not now. Expectant management with continuous fetal heart monitoring. What do you think? Looks like it can work, right? But this is delayed second stage, right? But let's put it in the option. Fetal scalp electrode and monitoring. No, I don't have any indication for fetal scalp electrode. Keyland rotational forceps. Why keyland and why rotational? Keyland is for mid-cavitary deliveries, okay, and this is +2. No. Low or mid cavity forceps. Yeah, it can be low forceps. If I apply a forceps, it will be low, but not a mid cavity. So this answer is not correct. Manual rotation followed by forceps delivery. No, why? He didn't give me anything regarding the rotation. Okay. Outlet forceps. Is that outlet? +2 is not outlet. So no. Okay. Rotation with vacuum cup followed by delivery. He didn't give me anything to say she need rotation. Did anybody say she need rotation? No. Trial vaginal delivery in operating theater. No, I don't have an indication for operating theater yet. Right? Ventouse delivery with kiwi cup. Maybe. Yes, maybe. Okay. So I do have now G versus O. Right? Where? Again. Okay? The 2 hours, right, in the second stage, not delivered yet. This is a small cabotant, yes. This is a small cabotant, not contraindication for ventouse. Okay. So what do you think at the moment, my friends? What you will do? Will you still wait after 2 hours, right? Or will you give a hand by the ventouse? Yes. So now, because they said after 2 hours, you can consider the assisted vaginal delivery. Before that time, dear friends, before the update of the assisted vaginal birth guideline, it was like a gray zone. We were not sure, okay, whether to wait for some time, like give her sometimes assist after 30 minutes, after 15 to 30 minutes, okay, or to go for the assisted vaginal birth at the moment, okay? But since we have in the GTG nowadays a clear guidance, okay, that says for a primary with epidural, okay, after 3 hours, you can offer her assisted vaginal birth, or without epidural, then after 2 hours, advise assisted vaginal birth, or it's an indication for assisted vaginal birth. In the NICE guideline, it consider 1 hour, okay, of the pushing in a woman who is primary and not yet delivered, okay, 1 hour of active pushing. So with sign of progress, I can give more time. However, if the birth is not imminent after 2 hours of pushing, refer the woman for a senior review and decision on place for the mode of birth. Okay? Clear, my friends? Okay. So I would choose O at the end. It's the most suitable one. Okay? She is encouraged to push, and 2 hours later. 2 hours later after what? 2 hours after pushing. Yes, to 2 hours pushing. Right? Everything is reassuring, yes, but this is a delay in the second stage where we can give her option of assisted vaginal delivery. Right? As I told you, my friend, like for example, all the answers, okay, before that GTG, okay, we used to say that if the situation is reassuring, we can give some time as per our clinical experience. But now we do have a guideline with advice, so we have to do it. Okay, so no problem, Dr. Rahul. If you think that this is based on a clinical judgment, you will go for give more time, give more time. It's your choice. Okay. If only low forceps, I will go for forceps better than ventouse. Yes. Whenever you have a forceps delivery, you go for it better than the ventouse. Unless you have a contraindication, which is few actually for forceps. Okay. A 29-year-old lady present with PPROM at 34 weeks of gestation to the delivery suite. She's not in active labor and receive a course of steroid and erythromycin. So she had a PPROM and not an active labor. She presented 2 days later feeling unwell. The abdomen show soft, non-tender uterus with reassuring fetal heart rate. Labor is induced in view of raised C-reactive protein. At 4 p.m., her cervix is found to be 4 cm dilated with absent membranes. 4 hours later, cervix is found to be fully dilated and she's encouraged to bear down with contractions. 2 hours later, okay, so she encouraged to push, okay? Fetal heart monitoring reveal late decelerations and vertex +2 station with left occipital anterior position. Can I apply ventouse in this case? No, of course, she is already 34. Yes, it can be considered, but not the best option. Yes, not best option, believe me. Okay, so 1 second, my friends. Okay, 1 second, because yeah. Will I deliver in room or theater? Okay, so just guys corrected the options. Sorry, my mistake. Okay. Okay. So at the moment, my friends, for late deceleration and delay in the second stage, will I have any chance to wait or shall I proceed now? I will proceed. If rotation is less than 45 degrees, shall I do it in room or in theater? In the room, right? So here, left occipital anterior. So if this is the occiput here, right? And it's anterior to the pelvic, okay? And this is the posterior, right? And yeah, it's left occipital anterior. If this is the right side, and this is the left side, okay? So it's here. If it is here, do I need theater for it? I don't need theater for left occipital anterior when it is low station, right? Because the rotation is not, yes, is not more than 45 degrees, right? This is what we call left occipital anterior. If it is transverse, means that we need 90 degrees of rotation. So we will go theater, okay? So left occipital anterior is good option, is good. Yes. Okay, so I will go for the low cavity forceps in room or in theater? In room. Okay. No, now I have to choose between forceps and ventouse. No, ventouse. I will not agree for the ventouse in this case. Why? Because it carry risk in preterm delivery. Yes, it's not contraindicated, but they said use with caution. So better to go for the safe option of forceps. Why manual rotation? Why would I apply manual rotation? It's very easy. It will come with any forceps. I don't even need a rotational forceps for this. Just a low cavity. Okay, so this is the answer J. You know, dear friends, in the previous before the 2020, okay, in the previous training for this exam and the preparation, we used to have conflict in answer in the assisted vaginal birth. So most of the questions, for example, or question banks that's not updated after the 2020, you will find different answer. You know why? That's because answers were depending on only clinical judgment, okay? So the author point of view, but we don't have a clear zone of recommendation. Now the guideline makes very clear, okay? When to go for rotation, when to go for theater, when to go for room, okay? When it is a low cavity, when it's outlet, and so on, okay? Forceps, okay, one second. So many questions are there. Let me answer one by one. For forceps, it should be direct to occipital. No, why? Forceps is very good tool that can help with rotation, okay? And even corrective asynclitism. So Keeland, for example, if I need rotation, I will go for Keeland, right? So it doesn't need to be direct occipital anterior or posterior for a forceps delivery. No, doesn't need. Left occipital posterior, is rotation required? Yes, of course. Okay, so simply look here. Let's consider this is the fetal skull. Yes, this is the guidance for you. Guys, let's say this is the occiput. Okay, and this is the anterior above here, and the posterior is below here. Okay, and the guidelines say if less than 45 or 45 degree of rotation, okay, so that's mean it's not rotational delivery, okay? 45 or less. More than 45 is considered as rotational delivery. Okay, so let's see here, okay? If I have occiput, left occipito posterior, means that the occiput is here. In my case, in my baby, occiput, I examined, I found that the occiput is here. To deliver it correctly, I need to turn, look, rotate, 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 rotate to the anterior, to the occipito anterior position. This is a significant rotation. Okay? While left occipito anterior is here. See the difference? Can you see, my friend, the difference between left occipito anterior and left occipito posterior? Big difference. Right? So I need only minimal rotation. Actually, it's considered non-rotational delivery. Okay? Next question. Occipito posterior at +2. All, will I do rotation or deliver as such in occipito posterior? I can deliver, look my dear, I can deliver, okay? If it is a direct occipito posterior, it may be considered to deliver low or outlet, okay? In a direct occipito posterior, but otherwise, occipito posterior will need rotation. Repeat the rotation and the application accordingly. Okay, Dr. Nahid. So simply, I will revise with you guys part of the guideline, okay, where you decide for the rotation or non-rotation. So if I have +2 station, +2 station with minimal rotation, it's considered no rotation. This will be in the room, delivery in the room, okay? +2, +1 at 0, no problem, but need rotation, go to theater. Okay, friends? When use ventouse in general, at what station? You will use ventouse at any situation when the ventouse is the only available answer. That's it. Okay? Just to know what are the contraindication of ventouse. Like, for example, after coming head, how you will deliver after coming head with ventouse? No, it's not. Preterm delivery, especially before 32. This is contraindication for ventouse. Use it with caution between 32 and 36. So it's not advisable very well. Face presentation, no ventouse. So you just know what are the contraindication of ventouse. Otherwise, okay, low risk delivery, need assisted vaginal delivery, and what I have available option correctly is the ventouse, go for the ventouse, no problem. Okay? But if I have to choose between forceps and ventouse in one option, both are applicable. Go for forceps because it has a higher rate of success. Occipito posterior, we apply forceps in room according to the situation, my dear. Okay, according to the station, like occipito posterior at +1, of course, no room. You will go theater for a rotational mid-cavitary delivery, right? I have a video, by the way, okay, small video in the group, in the WhatsApp group for the decision making in instrumental vaginal delivery, which is very important. So please refer to this video. I will share it with you. Okay, so you will solve the dilemma, okay, of the assisted vaginal birth. But before you go for the video, I need you to open the assisted vaginal delivery guideline, have a look to the tables there, okay, and then open the video. You will find it very easy afterwards. Inshallah. Keelan, the indication. Okay. Keelan, there is a mid-cavitary forceps when you need rotation. It's the best for mid-cavitary delivery and rotational. Can I apply forceps at 0 station? Yes, why not? Of course, you can apply forceps in 0 station. Right occipital anterior, left occipital anterior, or rotation less than 45, no need for rotation. Okay? If whatever the situation, please try to draw the head. This is your anterior, okay? This is your posterior. And see, where is the situation? He told you right occipital transverse. So locate it here and think how many, degree I need a rotation here. You will find simply it's 90 degrees. So this is need theater, and I will go to theater. Okay, he told you left occipital posterior. It's here. It's a long way till you reach to the anterior. It needs rotation, it needs theater. He told you left occipital transverse. That's here. Okay, need also 90 degree of rotation, right? He told you left occipital anterior. So left occipital anterior, so this is acute angle, right? No need for rotation. Since it's an acute angle from the anterior, no need for rotation, easy, right? Mid-cavitary and rotation, anywhere, modality, low or outlet. Mid-cavity is 0 and +1. Okay? 0 and +1 is mid-cavitary. Occipital-posterior at +1 can deliver that such. Try and tell me how you will deliver a mid-cavitary, need rotation, how you will deliver as such. Thank you very much. A 30-year-old primate is admitted in spontaneous labor at term. She had good uterine contractions. The partogram revealed cervical dilatation at 12 noon. Okay? To be forced at 4 p.m. At 4 p.m. is 5. Not good. Okay? It's not good. Oxytocin infusion is started at 8 p.m. She's found to be fully dilated. Right? Oxytocin infusion is started at 8 p.m. She's found to be fully dilated. Okay, so that's good after oxytocin. After she's fully dilated, she was encouraged to push. At 10 p.m., vertex is found to be +1. Station with right occipital transverse position. Manual rotation is attempted twice, followed by rotation with kiwi under pudendal block, but unsuccessful. Of course, it will not be successful. Position is still right occipital transverse. What do you think? So now what you will do? Kiwi failed. He didn't say anything, okay, about progress or not progress, but position is still right occipital posterior. Sorry, transverse. Yes, fetal heart rate is not mentioned. Okay, can I go to a forceps or not? A chance. The guideline says you go only after failed kiwi or failed ventouse at low station. Did he say here low station? No, he didn't say low station. So what is the rule? Now, where I will go? I will go theta. Okay? I will go theta. Yes. So, yes, no doubt you have to go to theater. Okay, so is it category 1 when you have failed instrumental delivery or category 2? Okay, I need to listen. Yeah, I need really to listen to your answers. Failed? Okay. Do you know what is the complication of failed vaginal delivery? Instrumental delivery? Anybody have an idea? Not because of the delay, to be honest, Dr. Hiba. Yes, impacted fetal head. What else? Increased risk of what? After the 2 trial of rotation and the kiwi. Okay, fetal hypoxia. What else? What else in the fetal brain? Head. Risk of intracranial hemorrhage on the baby. So you have impacted fetal head, right? With failed instrumental delivery. And non-rotational, right? You have tried and failed already. With congestion of maternal pelvis and high risk of trauma. And you still want to wait? Why you want to wait? Give me a reason why you want to wait. Guys, it came in your exam for a few times. Since 2020, they ask this question, right? And they want you, right, to choose. Failed instrumental delivery. And by the way, this instrumental delivery, where it is room or theater. This is +1 station, right? Should be where? Should be, right? Turn it to category 1 cesarean section, please. Right? Okay, are you going to wait for 70 minutes? You are in the theater and you are going to wait for category 2 cesarean section, or you will open the patient? Open up. Yes, proceed. Proceed to category 1 cesarean section, please. Right? Okay, I have option A. Why not option A? Do you have indication for general anesthesia? Any indication? I don't have an indication for general anesthesia. So why not? Why not A? Category 1. Failed instrumental delivery, category 1 cesarean section. Why? Because increased risk to both mother and fetus. The situation does not really, okay, require more waiting. If she is delayed second stage with good CTG, wait. Delayed second stage, no problem, wait. Okay, but you have tried already intervention. You have tried rotation and failed. Kiwi and failed. Impacted fetal head. This is obstructive labor. And plus, you are trying with an instrument. You're not convinced and you want to go for category 2 cesarean section, go. I don't mind. Okay, thank you. Thank you very much. So, Dear friends, I don't have a reason, okay, for general anesthesia, so I will go for the option with abundant vaginal delivery and proceed with category 1 cesarean section. Okay. Thank you very much, my dear friends. I want to give you one important advice, one last advice before we go, before the last question. Okay. What is this? Please don't go to this exam without a very clear concept in instrumental vaginal delivery. If you have a doubt in answer of instrumental vaginal delivery, no, okay? Stay awake. See, I'm telling you, relax, meditate, go to sleep, anything. No, don't sleep unless you study this, okay? Because no way you pass the exam without a good decision-making on instrumental vaginal delivery. Both instrumental vaginal delivery and intrapartum care, right, by the NICE guideline are very important guidelines, right? Why? Because you will find that the obstetric paper is full of labor scenarios. If you're not able to answer them, finish the exam. Okay? Occipital posterior plus 2 theater. Okay? Not true. Any rotation more than 45, you will go to the theater. Okay? Yes, I will send, of course. Of course. Very important. Yes, and I can see some of the candidates, our friends today, they have some lack of knowledge in this important guideline. I hope that they are all going for July, not January. Okay? If you are in January and you don't have enough knowledge of this guideline, you are in a critical situation, finish the session now and go study. Okay? Dr. Ahmed Mustafa. يعني okay. Direct occipital posterior plus 2 need rotation. Yes, you need rotation. Yes, the rules say yes, you need rotation. But it say also in the guideline, an exception is you may deliver in a direct occipital posterior. So when it is may, is that the rule? Or this is the exception? This is the exception. Okay? Okay, last question today. 29-year-old Primey is admitted in spontaneous labor at 39 weeks of gestation. She is known to have idiopathic thrombocytopenic purpura, and she is on steroid. Current blood report is normal. She is noted to be fully dilated with vertex at 0 station 4 hours after admission. Amniotomy is done, and she's encouraged to push vertex in left occipital anterior at the pelvic floor level. Pelvic floor level, this is good. Okay, fetal heart rate show late deceleration. So now I need to do something. What are you going to do in this case? Please help her. When the patient have thrombocytopenia, is that a contraindication, complete contraindication for instrumental delivery? No, it's not complete. So I will avoid mid-cavitary and rotational, right? But outlet is fine. Okay? So will you agree for outlet? Forceps? Yes, please. Yes, well done. So this one was easy, and I'm so delighted that you got it correct. Thank you very much, my dear friends, for your time today. Thank you for attending this session. I wish you all the best in your exams. Okay, I'm going to send you this file right after the session. I will send you the record as well, and I'm going to send you again the decision-making algorithm for assisted vaginal birth. It's very important before you go to the exam that you clear assisted vaginal delivery. Okay, friends? I'm so sorry because we don't have so much time to discuss more of your doubts today, but I wish, okay, that you return back to the previous videos or return back to the advices in the group. If you still have doubts, okay, or you still, even after you study or revise, have questions, please post it to the WhatsApp group and I can, inshallah, answer it all before your exams. Okay. Yes, my dear. I love you so much. I pray for you so much. You can't imagine. I feel like I'm going to the exam with you. Okay. Next week, inshallah. All the best. All the best. Wish you all the best of luck. I know, guys, you have worked hard and you deserve, inshallah, all you deserve is success. Thank you very much. Thank you, Dr. Suhail. Thank you very much, my dear friend. Thank you, Dr. Rehab, Dr. Nada. Thank you. Take care of yourself, my friends. Okay, Dr. Nahid, I will try to send really. Okay, maybe no time for a live session, but I will send a recording, okay, a video record trying to clear the doubts in labor, inshallah. Thank you very much, my dear friend. Thank you. Assalamu alaikum. I love you, all of you. Yes, pelvic floor means it's outside, plus on name. Thank you very much.